The average insured American family pays over $23,000 a year in premiums. Millions still can't afford care. That's not random. 5 documented practices are built to collect your money while blocking what you actually receive when you need care. From vanishing doctors to hidden charges, each tactic exploits a different gap between promised coverage and reality. The first red flag strikes the moment your plan renews. Number 1, narrow provider networks can quietly erase your access to trusted doctors the moment your plan renews. Each year, insurers adjust their networks, often shrinking them without clear warning to policyholders. According to a 2022 Health Affairs study, plans sold on the ACA marketplace have networks that are about 34% narrower than typical employer-sponsored plans. That means fewer in-network choices and a much greater chance your primary care physician or specialist will disappear from the list overnight. Consider the case of a family who confirmed their cardiologist was in-network before re-enrolling in January. After a routine visit, the bill arrived coded as out-of-network. Only later did they discover the insurer's online directory had been quietly updated after renewal, reclassifying the doctor and leaving the family responsible for $8,000. Screenshots from before and after the change became essential evidence in their complaint to the state insurance department. This kind of directory churn is not rare. Insurers may send a brief renewal notice, but most people never see a clear alert that their provider's status has changed. The financial risk is real. A single visit can generate thousands in surprise bills if your doctor is suddenly out of network. To protect yourself, check your insurer's provider directory every January. Do not assume last year's coverage still applies. Take screenshots of your doctor's network status before seeking care, and keep copies of any insurer communications. If you are hit with a surprise bill after a network change, file a detailed complaint with your state insurance commissioner and include all supporting documents. This paper trail is often the only way to challenge an out-of-network charge and push back against insurers who quietly narrow their networks while collecting the same high premiums. In second place, prior authorization denials stand as a major obstacle between patients and the care their doctors recommend. Even after finding an in-network provider, the approval process for essential treatments can grind to a halt. According to a 2023 survey by the American Medical Association, 94% of clinicians reported that prior authorization requirements delayed necessary care, and 1/3 witnessed those delays result in serious patient harm. The Centers for Medicare and Medicaid Services reports that marketplace plans deny between 5 and 17% of all prior authorization requests, rates that translate to thousands of patients left waiting, sometimes with life-threatening conditions. The impact is not just theoretical. Real-world cases show patients forced to pause cancer therapies, postpone surgeries, or go without critical medications while insurers demand more paperwork or issue generic denials. These delays can lead to emergency hospitalizations and, in some cases, permanent health setbacks. Yet many denials are not the final word. Data from the Kaiser Family Foundation reveals that about 30% of internal appeals succeed, and roughly half of external appeals overturn the insurer's decision. The key is to act quickly. Request a written denial, review the stated reason, and file an appeal with supporting medical documentation. If the insurer still refuses, escalate to an external review through your state insurance department. Keep every letter, denial notice, and clinical note. These records form the backbone of a successful appeal. Prior authorization is designed as a gatekeeper, but persistence and documentation can break through the barrier and restore access to the care you are already paying for. Third on our list, surprise facility fees have become a costly trap for patients who think they are visiting an in-network doctor. When a hospital acquires an independent physician practice, the billing structure changes overnight. That same office visit is suddenly classified as a hospital outpatient service, triggering a separate facility fee on top of the doctor's bill. According to a 2022 analysis attributed to KFF, these facility fees can add an average of $1,372 to the cost of a routine outpatient visit. In real-world terms, patients have reported receiving two bills for a single appointment, one from the physician and another, often much larger, from the hospital itself. The explanation of benefits may list separate CPT codes, one for the professional service and another for the facility, each with its own cost-sharing requirements. For families already paying thousands in premiums, these hidden charges can be a financial shock, especially when they appear after the care has already been provided and approved by prior authorization. To avoid being blindsided, always ask the scheduler before your appointment, is this office billed as a hospital outpatient department, and will I receive a facility fee? If the answer is yes, request a written estimate for both the physician and facility charges, or consider seeking care at an independent practice. Document the response and keep it with your medical records. If a facility fee appears on your bill unexpectedly, challenge it in writing and submit a complaint to your state insurance commissioner. These steps will not eliminate the risk entirely, but they can provide leverage if you are hit with an unanticipated charge. Hidden facility fees are a prime example of how insurers and hospitals inflate costs even when care is technically covered, turning approved access into a new source of profit at the patient's expense. Number 4, step therapy, often called fail first, forces patients to try and fail on cheaper drugs before an insurer will cover the medication their doctor originally prescribed. Insurers promote this as a cost-saving measure, but for patients, the consequences can be severe. According to a 2019 survey by the Alliance for Patient Access, 75% of physicians reported seeing patient harm directly linked to step therapy protocols. The harm is not abstract. Delays in getting the right medication have led to hospitalizations, worsening conditions, and even long-term complications. One documented case involved a patient who needed a specific biologic for a chronic illness. The insurer required 2 rounds of less effective medications first, resulting in a flare that sent the patient to the emergency room. Despite the risks, step therapy is now standard in most commercial plans, but there is a path to fight back. More than 30 states have passed laws that let doctors request an override when step therapy would endanger a patient's health. The override process usually requires a form stating the medical necessity and evidence of prior adverse reactions or likely ineffectiveness. When a doctor invokes this right, the insurer must review the request quickly, often within 72 hours or 24 hours in urgent cases. If the override is denied, patients can appeal and in many states escalate the case to the insurance commissioner. If you are told you must fail first on a different drug, ask your clinician to file a step therapy exemption immediately. Request a copy of the override request and keep it for your records. If the insurer refuses, cite your state's step therapy protection law and file a formal complaint. These legal tools exist to prevent insurers from prioritizing cost over patient safety, but they only work when patients and doctors use them. Number 5. The annual deductible reset trap quietly drains thousands from families already struggling to keep up with rising health insurance costs. Most plans are structured around the calendar year. That means every January 1st, your deductible resets to 0, no matter how much you paid just weeks earlier. A Peterson and KFF 2022 analysis found that a large share of Americans now face deductibles of $1,000 or more, with many plans exceeding $2,000. For patients who hit their deductible late in the year, for example, after a November surgery or a December hospitalization, this accounting trick can double their out-of-pocket burden. One documented case involved a patient who satisfied a $2,000 deductible in November, only to be billed again for the full deductible in January when follow-up care continued. The result, 2 explanations of benefits, 2 rounds of bills, and a financial shock that wipes out any sense of security the insurance was supposed to provide. This reset is not a glitch. It is a built-in feature of most employer and marketplace plans, and insurers are under no obligation to coordinate costs across years. The impact lands hardest on people with chronic conditions or ongoing treatment needs, forcing them to pay twice for a single episode of care. To avoid falling into this trap, timing is everything. If you reach your deductible in the fall, work with your doctor's office to schedule any planned surgeries, imaging, or medication refills before December 31st. Ask for a written estimate of your remaining out-of-pocket costs and confirm with your insurer whether upcoming services will count toward the current or next year's deductible. Keep copies of all explanations of benefits, especially those dated near year's end. If you receive duplicate bills for the same care split across 2 years, file a complaint with your state insurance regulator and request that overlapping charges be credited. With careful planning and documentation, it is possible to limit the financial damage from a system designed to make patients pay twice. Across all 5 red flags, one reality stands out. Insured Americans face a system engineered to collect high premiums while erecting costly barriers to care. These are not isolated glitches. They are deliberate features. In this landscape, vigilance is not optional. The true cost of coverage is measured in denied care, not just dollars.